Hello and welcome to this Junior Emergency Medicine lecture on pneumonia and sepsis. My name's Ben. I'm a doctor currently working in Leicester, and I'll be taking you through for the next half an hour or so the principles behind pneumonia and sepsis. Listen carefully because you'll need this knowledge and the skills from it to succeed in your simulation days, which will be coming up soon. So today we'll be looking at first, what is pneumonia? You might have heard of it before. You might not. We're going to cover it in a good amount of detail for you. We're also going to look at sepsis. Again, this has been something that's been in the news quite a bit, so you may have heard of it before and might already have a lot of knowledge on it. But we're going to be giving a good recap of sepsis today. We're also going to be looking at how to recognize pneumonia, what investigations we are going to do for sepsis and pneumonia, how we're going to treat pneumonia, and we're also going to be doing a patient case. So going from as they walk into the emergency department to discharge home. Also, just to note, these original slides were provided by Dr. Rick Potts, and then I've revised them a couple of years ago when I first gave this lecture. So to start off, what is pneumonia? So pneumonia is a lower respiratory tract infection. So what do we mean by that? So we have our respiratory tract, which goes from our mouth all the way to the bottom of the lungs, and is what we use to breathe. The end result is gas exchange. So in the alveoli, the smallest air spaces in the lungs, we take in oxygen to the blood and we kick out carbon dioxide, which is then breathed out. Our lower respiratory tract specifically is from the primary bronchi, so that's where the main airway, our trachea, our windpipe, branches into two, and into all of the smaller airways down to the alveoli at the smallest part. And a lower respiratory tract infection or a pneumonia is infection of any part of that system. Okay. And just to further illustrate that, the alveoli are normally affected and they fill up with microorganisms, which are usually bacteria. There can be fungal pneumonias and viral pneumonias, but we're talking more about a bacterial pneumonia today. These air spaces also fill up with inflammatory cells and fluid, which are produced by the immune response. So here we have a normal alveolus, and here we have one affected by pneumonia, which is full of fluid. And this makes breathing more difficult. Before, where you had a nice clear alveolus, gas can be exchanged across the membrane really easily. Whereas if you're having to push your oxygen and your carbon dioxide through a load of fluid, that's going to make it a lot more difficult to breathe. And we can diagnose pneumonia on a chest x-ray, which we'll look at later, because you can actually see this fluid sat in the lungs instead of nice clear air spaces. But we'll see that later on in the presentation. Okay, so now we've got a bit more of an understanding of what pneumonia is. So it's a chest infection, put simply. So let's have a think about how one of these patients will present to their GP, to A&E, or to somewhere else for medical attention. So think first of all, now knowing a little bit about what pneumonia is, what symptoms would you expect this patient to display? So take a moment just to write down what you think the patient might have in terms of symptoms. You can of course pause the video if you need to, just to give you a bit of time. So I'll give you a moment or two just to write down what symptoms you would expect a patient with pneumonia to have. Okay, so let's think about what pneumonia will look like. So specifically, signs and symptoms. So signs are something that you as the clinician finds by examining the patient or by looking at the patient, and symptoms are the things that the patient comes to you and says, this is what's wrong with me. So if you've had a stinker of a cold, or maybe you've had a stinker of a chest infection as well, you would probably have a cough. So for an upper respiratory tract infection, which is a cold, you're trying to clear the mucus and the snot and all those things out of the back of the throat, nose and mouth. In a chest infection, it's similar. You're just trying to move all that mucus and rubbish off the chest and out of those air spaces rather than from the nose and the mouth. So there you are. There's a patient. They've got a horrible cough. And this cough can be productive as well. So a productive cough is one in which you're bringing something up, you're producing something from the cough. And this can be mucus. And unlike a cold, where you might have a bit of green mucus, and that's about it, really, with a chest infection, you can brew all sorts of fantastic colours of mucus. So you can go from yellows, greens, browns, and even in some cases, blood-stained mucus as well. The patient would also feel breathless. The reason for this is because your alveoli are full of fluid and rubbish, which is making it even more difficult for gas exchange to take place. You're not getting enough oxygen to your tissues, you increase your breathing, you feel breathless. You may also have a painful chest. So if the inflammation of the lung lining is bad enough, you can get pain in that area, and that's a symptom called pleurisy. So it's a sharp pain in the chest over the area where there's inflammation. And that can be really quite distressing for some patients and can contribute to the feeling of breathlessness. So painkillers are a key consideration here as well. And this is a really significant symptom that I want you to remember is fever. So fever usually means infection. Fever is the body's response to infection. It's a immune part of your immune response and is used to try and reduce the activity of the bacteria or the microorganism causing the infection by raising the body temperature. So if they have a fever, think infection. And with a fever, if you've had one before, you might know that you can feel very sweaty because you're hot, and you might also feel shivery or shaky as well. And that's called rigors. So that shaking that you get with a fever, that's called rigors. And generally, you'll just feel rubbish because you're fighting off a horrible infection, along with all these other things like feeling breathless, painful in the chest, and feverish. And what comes with that is general fatigue because you're using your energy to fight the infection, and that'll leave you feeling washed out as well. In most severe cases, it can also mean that patients become confused, and that's a key indicator for severity of infection. Okay, so now let's talk about the complications of pneumonia. So if a patient who has a bad chest infection stays at home, tries to tough it out, doesn't want to see the doctor, complications can arise. Or if the patient has been treated and they don't respond properly to the treatment or aren't strong enough to respond to the treatment or may be frail or maybe any other reason, they may develop complications. And the key one to be aware of is sepsis. So just ask, could it be sepsis? And that's something you want to keep in your mind whenever you've got a patient with an infection is, are they developing sepsis? So let's talk a little bit about sepsis now. So what is sepsis then? So sepsis is the uncontrolled response of the body to severe infection. So let's first think about our normal response, and then we can think about how sepsis is different. So our response includes a high temperature. So this is part of your immune system and immune response to infection to fight off the infection and stops bacteria from multiplying. We also have activation of inflammatory cells. So this is your immune system kicking in. So white blood cells are our main component of this. And we also get a little bit of vasodilation as well. So that's widening of the blood vessels to increase blood flow to the infected area. That allows immune components and white blood cells to be delivered to that area to fight the infection. Now, let's consider sepsis. So if this response becomes uncontrolled, we have a very high temperature, overactivation of inflammatory cells, which then leads to not just local vasodilation, but systemic vasodilation. So widening of blood vessels throughout the body. This is dangerous because this can lead to further issues. So systemic vasodilation caused by that overactivation of inflammatory cells will lower the blood pressure. So if you've got a system of pipes which you've just doubled the size of, you're going to get a lower pressure running through those pipes. And that's essentially what's happened here. The body tries to adapt to that by increasing the heart rate to try and push more blood around now that blood pressure is lower. This is because there's a low blood supply to the organs. So because of the lower pressure, less blood is being delivered to the organs and there's less blood going to them. Now, this is problematic because it can cause damage to the organs and stop them from functioning properly. And a key organ that we want you to remember is the kidneys, because the kidneys are very sensitive to changes in blood flow. When they experience reduced blood flow, they reduce the amount of urine they're producing because they're less able to work, and that's their main function, is producing urine. So patients with sepsis will have a low urine output. The patient might also have a fast breathing rate and low oxygen saturations as well, because in this case they've got a pneumonia which they're fighting against, and they're trying to get extra oxygen to the blood to give those organs a better fighting chance. And so just to sum up, this low blood pressure is causing poor blood supply to the organs and the peripheries, which can then cause organ failure and death. This is why sepsis is so important to not be missed and to be treated promptly. And this is why it's so important to be aware of sepsis, is that it can be rapidly fatal, and in the patients that it doesn't kill, it can leave them disabled. And this is a key thing to know about for your interviews, because it is a hot topic in the medical world and something we're becoming more aware of nowadays. So we're going to talk a little bit about the kind of the broader recognition of sepsis. So each year, over 100,000 people come to hospital with sepsis in the UK. So it's not an uncommon issue. It's quite, in a normal emergency department, you'll see probably a couple a day. And that's definitely been my experience from working in hospitals. And this is the scary stat, is that of those patients, more than a third will die. So there's 100,000 people, 33,000 at least will die from this. And you can see why that's such a serious condition that we need to recognise early. So understanding those principles which we've just talked about are key. And the surprising thing really is that it's so easily treatable. Sepsis is treated with antibiotics, and if caught early enough, you can stop the patient from deteriorating, from dying. And the time to give antibiotics is absolutely key, because the longer you wait, the worse the outcomes become. And that's what sparked this campaign of surviving sepsis and the Sepsis Trust UK as well. And this is a real key thing, is that we have a golden hour. So within an hour of suspecting sepsis, you should deliver the sepsis 6. So we'll talk about that in a moment. One of the key parts of the sepsis 6 is antibiotics, and to get all these 6 interventions in place requires a well-functioning team and a multidisciplinary approach, so using all members of the team. So not just doctors, but also nurses and other staff in the emergency department to treat the patient rapidly, to stop them from being one of those third of patients that unfortunately don't make it out of hospital again. Talk about our clinical case. This is a real case of a real patient. So there's Linda. We have changed the name for confidentiality purposes. Here she is, and this looks a lot like Linda, although that's not really her. And she did have a small dog, quite like this. She's 78 years old, and she's been sent to the hospital today by her GP because she's got a really nasty cough and it's bringing up yellow mucus. She has a dog and usually enjoys going on long walks with the dog, but really doesn't feel up to it at the moment. And the GP thinks she has pneumonia. And you can already see there some of those symptoms. So a productive cough with yellow mucus, and also feeling tired and washed out. So let's see what happens when she comes into the A&E. So now we're going to try and help her out. And first of all, think about how you might assess this patient and what approach you might use. Have a look in your workbook if you need any pointers for this. So you should have identified that the first thing we need to look for is, in our A to E assessment, is airway. So she has told us she's not feeling very well, so she's able to talk to us. So that means her airway must be clear. If you were concerned about an obstruction, you can also look in the airway. So very, very quickly, we've cleared her airway, and we're sure that that doesn't need any further treatment. So we can move on to our next step. Okay, so we've done A, and we're going on to B. So if you've had a proper look at your assessments and in the workbook, and you can remember what we've covered already, B is for breathing. So what are we going to do in terms of breathing? Our first thing is our oxygen saturations. So as we mentioned before, a patient with pneumonia, because they're not able to move as much oxygen into the blood because of the fluid in the air spaces, they may have slightly lower oxygen saturations. And we measure that with our pulse oximeter, which goes on the end of the finger and will give us our saturations. We see that the saturations are at 88% on room air. So we're going to give them some oxygen. And a bit of a clue here, it's flashed up on the screen. This is our non-rebreathe mask, and we're going to give 15 litres of oxygen through that to push those saturations up. We're also going to look at the respiratory rate. So the patient might be actually breathing faster than usual because they're not able to get that oxygen into their blood, and they may be developing sepsis as well. So we're going to stand there and we're going to count the respiratory rate, and you'll be able to do that with the skills that you've learned already. And we're also going to have a look at how the chest is moving, so looking for how hard they're breathing, and then also if there's any injuries or any other marks or anything on the chest wall. So if they're using accessory muscles of respiration, so more than just the diaphragm and the rib cage, but also maybe some of the muscles in the neck, that's more concerning. And of course, we're going to listen to the chest as well to see if there's any changes in the sounds in the chest. I'm going to use our trusty stethoscope for that. And what we do here is crackles. So crackles is the sound of air bubbling through fluid, and it sounds almost like bubble wrap being popped. And that's where you can literally hear under your stethoscope the junk that has built up in the air spaces. So that gives us a real clue that yes, it sounds like the GP was right to send her to hospital because she's got a pneumonia, is what we're suspecting. Is C for circulation. So in this, we're going to use our approach of moving up the arm. We're going to start from the fingers and look at the capillary refill time. So her capillary refill time is more than 2 seconds, so it's prolonged. That's because her blood vessels have shut down in the peripheries to try and channel blood back towards the central organs because of the lower blood pressure, because of this onset of sepsis. So that's going to be delayed. Her heart rate is also going to be increased. We can feel this at the radial pulse in the wrist, and if that's not present, that means the blood pressure is very low, and we'll need to feel for a central pulse, for example, at the carotid or the femoral. So she's got an increased heart rate because she's experiencing sepsis and is fighting off this infection. Moving up the arm, we've already got some clues here that the blood pressure is lower than we should hope for. And when we take it, it comes back as 90/60. So that's quite low actually. And the blood pressure should normally be between 120/80 and 130/90, roughly speaking. So what we're going to do, we're in and around the elbow. She's got a low blood pressure. We know we're going to have to treat her. So we need to get in a cannula. So that is a small plastic tube which goes into a vein that allows us to take blood out and also give medications directly into the vein. Here's a range of cannulas from yellow on the right hand side being used for babies and small children to grey and a red cannula on the left hand side, which are big hose pipes used in traumas and cases where you need to get a lot of fluid in quickly, especially in things like obstetrics, so birth and delivery. And while we've got the line in, we can get some blood out. So we're going to take some blood tests for the patient. We're going to take, this is one of our pink top bottles for hematology tests, so blood tests. And this is going to give us our full blood count. And that'll give us our white cell count, which we know is going to be raised because of the infection that we're fighting off. We're also going to take blood cultures. So this is a sample of the blood, which we're going to try and grow in a Petri dish to see whether there's any bacteria in the blood, which would indicate a severe infection or sepsis. And because she's working really hard with her breathing, we're also going to want to take a sample of blood from one of her arteries, so that an ABG. We can see here that the practitioner is taking blood from the wrist, from the radial artery that you can feel in your wrist. Now, this is to get a more accurate look at the oxygen levels in the blood, because this blood has come from the lungs directly as it's arterial blood. And we're going to give what we need. So we're going to give, in this case, antibiotics because we're concerned about sepsis. And we'll talk a little bit more about the sepsis 6 and the components of that in a few slides' time. We're also going to want to give fluids at this point because she's got a low blood pressure. So we can give a bolus of fluids. So 15 minutes, 500 mils of normal saline. And that is going to help push that blood pressure up and improve perfusion to those organs which are currently not getting what they need. We can also listen to the heart sounds as we come round off the top of the arm onto the chest, and these sound okay to us. And we can also get an ECG just to make sure that there's nothing going on cardiac-wise which is causing her symptoms. So we've gone through the first 3 steps of our A to E assessment, and we've treated each of the pathologies as we've gone along. So what's next is D for disability. So what are we going to do in disability? So first of all, capillary blood glucose. So we need to check this because unwell patients can have abnormally low or high glucose levels. It's important that we check this so we can treat that early because it can lead to complications if missed or not treated. We're also going to check the patient's temperature. So our patient might be having a fever, or their fever might have broke and they might not have a fever at the moment. Remember, presence of fever, you should think infection. So our normal range for temperature is usually 36.5 to 37.5, with our maximum upper and lower bounds 36 to 38 degrees. We can also check the patient's conscious status. So we can do this via our AVPU. So the patient is alert and talking to us, so we're happy with that already. We can also do it more formally in terms of the GCS, which is a scoring system used for patients, which is scored out of 15. That's more for another day. And we'll also want to check the patient's pupils to see whether they're functioning normally and whether the brain is functioning normally. The pupils should be equal and reactive to light. And last but not least is E for exposure. So we're going to look at the patient top and bottom, back to front. So we're going to look first on the top half, covering the bottom to make sure there's no injuries, wounds, anything else of note to the head or chest or arms. And then we're going to do the same on the bottom half, so the thighs and the legs, to make sure there's no injuries or anything else that we need to be concerned about. We're also going to look at the back as well to make sure the same again. We also at this point want to check the patient's urine output to make sure that they are producing enough, because if they are septic, this might be affected and is a key indicator of severe infection. So let's talk about some of the investigations we've done for this patient. We're going to want a sputum sample. So we're going to want a sample of the mucus that she's coughed up from her lungs so we can grow it in the lab and find out what bacteria has caused this infection. This then allows us to give targeted antibiotics. We're also going to want to do some routine blood tests, as we've already mentioned, a full blood count to look at those raised inflammatory markers, but also a kidney function. As we mentioned before, our kidneys can be badly affected early on in severe infection, so we want to check how well they're doing. We're also going to look at liver function and inflammatory markers. We're also going to want to have an X-ray of their chest to see if we can spot that infection and see whether there's any other complications of that infection. So here's a normal chest X-ray first of all, and then we'll look at our patient's chest X-ray. So we can see here the patient, and we've got to have to imagine that they're facing us, so sat towards us. So this is the left-hand side on this side, and this is the right-hand side on this side. So as if they're sat facing us. On our chest X-ray, we can see our lungs. So these are full of air, so they're black because the air passes. The air does not absorb the X-rays, so they can be hit on the detector, and that's why it comes as black. And then our whiter areas are the bones. So the bones are absorbing the X-rays, so they don't reach the detector, so they show up as white. We can also see our heart as well here, so sat in the middle and slightly to the left, and just coming a little bit round the back there as well. The heart is a muscle, so it's absorbing those X-rays, so shows up as white. We can also see we've got nice crisp edges to our diaphragm. So that's our big trampoline-like muscle at the bottom, which helps us breathe. And those are nice clean edges, so there's no liquid or anything else in the lungs that shouldn't be there. There's also a little bit of gas underneath the diaphragm, and that's our stomach because that's got gas in it from time to time as well. We can also look at our airway coming down from the top and splitting here and here. So those are our 2 primary bronchi coming off there, which we had a look at in a diagram a couple of slides ago. Okay, so that's what a normal chest X-ray looks like. Let's see our patient's. So this is our patient's chest X-ray. And again, start by just orientating yourself. This is the left side of the patient, and this is the right side of the patient. And again, we can see our airway coming down here. We can see our bones. We can see our ribs. Let's start off with the right lung. So this is our right lung because it's sat on the patient's right-hand side as if they're sat facing you. And here we can see nice crisp borders. See the ribs coming round. Nice crisp border at the bottom there. And Again, that's the back end of the heart, just sticking through here. That's all lovely and crisp. And we can see the airway coming down here and spreading off into that right lung. Let's have a look at the left lung. Okay, so we've obviously got a problem here. At the top, nice and clear. At the bottom, this horrible white mess of stuff which shouldn't be there. So something is stopping the X-rays in their path. The lung is not filled with air, it's filled with something else. And this is our pneumonia. That's all the fluid and junk stuck in the lung, which we talked about before at the very, very start of the lecture. This is how it looks on the X-ray. And we've completely lost the diaphragm here. You can't see it. So where here it's a nice clean line, here it's gone completely. And you can also see all this fuzziness here where we should see a nice heart border where the heart was before. It's all completely fuzzy and gone. And that's because we've got all this junk sat in the lung. So this is a lobar pneumonia. So it's in one lobe of the lung and it's on the left side. So it's a left lower lobe pneumonia. Okay, so our patient has definitely got a pneumonia. We've figured it out both from our A2E assessment and now we've got the confirmation on the X-ray as well. So we've identified our patient has a bad chest infection and is becoming more unwell as we speak. So we need to make sure that we're treating them for sepsis because we're concerned about that, and we need to treat them with the sepsis 6. So these are 6 key interventions that we need to do to help try and save this patient's life. Okay, and it's giving free things and taking free things from the patient. Okay, and actually you'll come to realize that because we've done a thorough and proper A2E assessment, we have in fact got a lot of these things already sorted. So let's go through them now. So our first one in a sepsis 6 is giving high flow oxygen to make sure that we can get as much oxygen into the body as we can to really help support the lungs that are already working hard and the circulatory system, which is already working really quite hard as well. So we're giving high flow oxygen. That's our 15 litres through the non-rebreathe mask. Check, we've already done that in our breathing part of our assessment. Next, we're wanting to give fluids. So that's IV fluid challenge to help prop up that blood pressure, which is dropping because of sepsis. And if you think back during circulation, when we put in a cannula, we've done just that. We also want to give antibiotics. This is the last of our 3 gives. And we've done that already. So when we put the cannula in, we identified that the patient had an infection and we were giving broad spectrum antibiotics at that point. So fantastic. Well done, team. We've already done the 3 gives. So what are the 3 takes? We want a lactate. So what is a lactate? A lactate is a blood test which shows how well the cells are being perfused, essentially. So because our cells are having poor perfusion, so they're not getting much oxygen, at the moment we're going to have a high lactate. And we didn't mention lactate at any point, but actually when we did our arterial blood gas from the wrist, remember that photo where we had a needle going into the wrist? That blood test will show us our lactate, and that will give an indication on the severity of this sepsis and how unwell this patient is. We also want to take blood cultures. So like with the sputum sample, where we're going to try and grow the bug, we're going to see if we can grow anything from the blood as well. And if you think back, remember those 2 large glass bottles we took? So the blue top one and the purplish top one, those were our blood cultures. So we've already done that as part of our A2E assessment. And then last, but very much not least, is our urine output. So as we've mentioned, our kidneys aren't working well, so they won't be producing as much urine, and that's a key sign that sepsis is on its way. And we haven't actually done that one yet. We would consider that an exposure. So we'd ask the patient, how much have you been passing urine? And if we're really concerned, we can even put a catheter into their bladder so we have an accurate monitoring of how much urine they're producing. And that would come under our exposure. So just to go over our management, we've done our sepsis 6. That's the key life-saving interventions that need to be done within the first hour. We want to also get senior help. This lady can potentially become very unwell very quickly, so we need to make sure that our registrar or consultant, so a more senior doctor, is aware of this patient and involved in their care. It may also mean that if she becomes more unwell, that we might need to refer to intensive care or the high dependency unit, so we need to have those senior doctors on board early to make those decisions should we need to. We're also going to want to give some painkillers If she has any chest pain, as we said before, that pleurisy, that inflammation of the lung lining, can be quite painful, so we need to consider that as well. We're also going to chase up our results from the lab to see what sort of bacteria is causing the pneumonia, and then we can narrow down from our broad spectrum antibiotics to give give an antibiotic which is specific to that bacteria to treat it. So, what happened to Linda? So she stayed in hospital for 3 days, receiving IV antibiotics and IV fluids. As her observations, so her heart rate, respiratory rate, and saturations improved, and her blood tests also improved when they repeated on the 3rd day, she was discharged home. She was given oral antibiotics to take at home for the next 2 days and went back to walking her dog soon after. So in summary, what have we covered today? We've looked at pneumonia and we've discussed what it is and how it occurs. Put simply, it's a chest infection. Sepsis, which is an uncontrolled response to the infection, and we've also looked at the sepsis 6 and the importance of doing that all within that golden hour. We've done an A2E assessment on a patient with signs and symptoms of pneumonia. We've also taken appropriate investigations from the patient, and we've also considered how we're going to manage this patient, namely with the sepsis 6 and with those other bits and bobs as well, including pain relief and asking for senior help nice and early. So we've covered a lot of ground in today's lecture, and I'm sure you've got plenty of questions. You can either ask me in person at the next JEM day, or you can also get in touch with us via our social media, which is on the screen there. I hope you've enjoyed this lecture, and it should stand you in good stead for your simulation days coming up. Best of luck in your future careers.